If your feet tingle at night, if your hands feel numb without an obvious cause, or if you experience burning, stabbing, or electric pain that no examination has been able to explain, the next few minutes may clarify something that years of medical appointments have not. This is not about managing pain. It is about understanding what is causing the damage and stopping it before it crosses the threshold beyond which recovery becomes significantly harder. Here is what this video will cover: the single most common and most overlooked source of nerve damage in older adults. Why you do not need a diabetes diagnosis for that damage to be actively occurring in your body right now. The specific daily inputs that accelerate it. The nutrients your nerves depend on that many seniors are quietly depleted of. And a set of concrete changes, not complicated, not expensive, that the research supports for slowing or halting progression. One statement up front, because it matters. Neuropathy is not always reversible. Nerves regenerate slowly, and in advanced cases, some damage is permanent. But in many cases, progression is stoppable. And stopping progression, less pain, better balance, fewer falls, preserved independence, is not a consolation prize. For most people dealing with this, it is the most meaningful outcome available. The window in which that outcome is achievable closes over time. That is why what follows is worth understanding now. Nerves are not wires. They are living biological structures that depend on a continuous supply of oxygen, nutrients, and stable internal chemistry to function. They are surrounded by a protective sheath called myelin, a fatty insulating layer that allows electrical signals to travel efficiently from the brain and spinal cord to the extremities and back. When myelin is damaged, signals become distorted. When the tiny blood vessels supplying the nerve with oxygen are damaged, the nerve itself begins to starve. Unlike skin, which regenerates rapidly, or muscle, which responds to stress by growing stronger, nerve tissue heals extremely slowly. This means damage accumulates quietly over time. By the time tingling, numbness, or burning becomes noticeable, the underlying damage has typically been developing for months or years. This is the central fact that makes peripheral neuropathy so difficult to address once it becomes symptomatic. The symptoms are late signals. The damage that produced them is old, and the inputs that cause the damage are frequently still operating, continuing to accumulate injury in tissue that has very limited capacity to repair itself. The most significant and most commonly overlooked driver of peripheral neuropathy in older adults is not a rare toxin, an unusual medication, or an uncommon disease. It is chronic blood sugar toxicity, repeated exposure of nerve tissue to elevated glucose levels over time. This requires an important clarification that most people have never heard. You do not need a diabetes diagnosis for blood sugar to be damaging your nerves. You need only repeated spikes above the threshold that nerve tissue can safely tolerate. And millions of older adults experience those spikes daily without a diabetes diagnosis, without being aware of the spikes, and without connecting them to the symptoms they are experiencing in their hands and feet. The mechanism is specific. When blood glucose rises acutely, glucose molecules bind non-enzymatically to proteins in the body through a process called glycation. In nerve tissue, glycation affects both the nerve fibers themselves and the endothelial cells lining the tiny blood vessels, called vasa nervorum, that supply the nerves with oxygen and nutrients. Glycated proteins in these vessel walls trigger inflammation, increase oxidative stress, and impair the vessel's ability to regulate blood flow. Oxygen delivery to the nerve drops. The nerve begins to function abnormally. Over time, if the exposure continues, the nerve degenerates. The progression follows a consistent pattern. Early damage produces tingling or mild numbness, frequently in the feet first, because the longest nerves in the body, which extend all the way to the toes, are the most vulnerable to cumulative toxic exposure. As damage progresses, burning pain, sharp electric sensations, and loss of fine touch sensation develop. In advanced neuropathy, proprioception, the body's sense of where its limbs are in space, is impaired, which directly and significantly increases the risk of falls. Here is the finding that most people with prediabetes have never been told. Published research now demonstrates that prediabetes, blood sugar consistently elevated above normal but below the diabetic threshold, causes peripheral nerve damage at nearly the same rate as full diabetes. The majority of people with prediabetes do not know they have it. Many have been told their blood sugar is a little high but nothing to worry about. That reassurance, while well-intentioned, does not reflect what is happening to the nerve tissue during those repeated elevations. The nerve damage is occurring. The diagnosis simply has not caught up with the biology. Understanding the primary sources of nerve-damaging glucose spikes is practical knowledge, because removing these inputs is the most direct available intervention. The first and most significant source is liquid sugar. Fruit juice, sweetened coffee beverages, sports drinks, and blended fruit smoothies deliver glucose to the bloodstream extremely rapidly because they contain no fiber, no fat, and no protein to slow absorption. Fiber is the primary modulator of glucose absorption speed in the gut. It physically slows the movement of sugar into the bloodstream by increasing the viscosity of gut contents and slowing gastric emptying. Remove the fiber, and glucose absorption becomes almost immediate. The resulting blood sugar spike is sharper, higher, and more damaging to nerve tissue than the same amount of sugar consumed in whole food form. The recommendation that seniors drink juice for easy nutrition is physiologically counterproductive for anyone with nerve symptoms or blood sugar concerns. A glass of orange juice produces a blood glucose response comparable to a glass of sugar water. The vitamins it contains are available from whole fruit at a fraction of the glycemic impact. The second source is refined carbohydrates consumed without accompanying protein or fat. Bread, crackers, cereal, white rice, and pasta break down rapidly into glucose during digestion. When eaten alone, as a snack, as a light meal, or as the dominant component of a meal, they produce the same sharp glucose spike as liquid sugar, though slightly slower. When eaten alongside protein and fat, the glucose response is dramatically moderated. Fat slows gastric emptying. Protein stimulates incretin hormones that moderate the insulin response. The same food that damages nerve tissue when eaten alone becomes substantially safer when eaten as part of a balanced meal. This single principle, never consume carbohydrates alone, is one of the most important and least communicated pieces of nutritional guidance for nerve protection. It explains why two people eating apparently similar diets can have dramatically different outcomes. It is not always what you eat, it is how you eat it. The third source is constant snacking throughout the day. When food is consumed repeatedly over many hours, insulin remains chronically elevated. Elevated insulin creates conditions of sustained metabolic stress in nerve tissue and prevents the recovery periods during which nerve repair processes can operate. Nerves require stable biochemical conditions to maintain their structure. Continuous glucose and insulin fluctuation keeps the inflammatory pathways that damage nerve tissue continuously active. 3 meals with clear intervals between them, rather than continuous grazing, produces a meaningfully different metabolic environment for nerve tissue. There is a secondary driver of neuropathy that receives very little attention in standard medical practice. Medication-induced nutrient depletion affecting the nutrients nerves specifically depend on. The most clinically significant example is vitamin B12. B12 is essential for the synthesis and maintenance of myelin, the protective sheath surrounding nerve fibers. Without adequate B12, myelin integrity degrades, nerve signals become disrupted, and the symptoms are clinically indistinguishable from those of blood sugar-driven neuropathy. Tingling, numbness, and burning pain in the extremities. Several medication classes that are extremely commonly prescribed to older adults reduce B12 absorption as a documented pharmacological consequence. Proton pump inhibitors and H2 blockers, acid-suppressing medications used for GERD and acid reflux, reduce the production of stomach acid that is necessary for B12 absorption from food. Metformin, one of the most widely prescribed diabetes medications globally, has a well-documented mechanism of reducing B12 absorption from the gut. Long-term use of both medication classes is associated with clinically significant B12 deficiency. The critical point is that many patients on these medications have never had their B12 levels tested, have never been told about this interaction, and are experiencing nerve symptoms that are attributed to aging or to their underlying condition, when the medication itself is a contributing cause. B12 deficiency severe enough to cause neuropathy develops slowly, over months to years of inadequate absorption. It does not announce itself dramatically. It accumulates quietly and produces symptoms that feel like inevitable age-related decline. Testing B12 levels is a simple blood test. If deficiency is identified, the correction, through supplementation, dietary change, or in some cases intramuscular injection when gut absorption is impaired, can stop that specific mechanism of nerve deterioration. What cannot be corrected is the damage that accumulated during the years the deficiency went undetected and untreated. Other nutrients with specific roles in nerve function include magnesium, which supports nerve signal transmission and reduces the cramping and twitching that frequently accompanies neuropathy, folate, which works in concert with B12 in the methylation pathways that support myelin synthesis, and alpha-lipoic acid, a compound with antioxidant properties in nerve tissue that has been studied specifically in the context of diabetic neuropathy, with some evidence for symptomatic improvement. One important caution on supplementation: vitamin B6 is frequently included in nerve support formulations and has a meaningful evidence base at appropriate doses. But B6 is also one of the few vitamins that causes nerve damage when taken in excess. High-dose B6 supplementation, typically above 100 milligrams daily over extended periods, produces a toxicity neuropathy that is clinically similar to the condition it is supposed to treat. More is not better. Supplementation should be guided by testing and clinical guidance wherever possible, not by the logic that if some is good, more must be better. Blood sugar toxicity and nutrient depletion do not operate in isolation. They operate against a background of systemic inflammation, and chronic inflammation significantly amplifies nerve damage through independent mechanisms. Inflammatory signaling molecules, particularly TNF-alpha, interleukin-6, and interleukin-1, sensitize the peripheral nervous system, lowering the threshold at which nerve signals are perceived as painful. This is why the same degree of structural nerve damage produces dramatically different levels of pain in different individuals. The inflammatory environment determines how loudly the damaged nerve broadcasts its distress. A person with high systemic inflammation experiences the same physical damage as significantly more intense pain than a person whose inflammatory signaling is lower. The dietary inputs that drive systemic inflammation most reliably are refined seed oils high in omega-6 fatty acids, refined sugar, highly processed foods broadly, and excess alcohol. The dietary inputs that most reliably reduce it are long-chain omega-3 fatty acids from fatty fish, polyphenols from vegetables and whole fruits, olive oil, and specific anti-inflammatory compounds such as curcumin from turmeric, which has a documented mechanism of inhibiting NF-κB, the primary transcription factor controlling pro-inflammatory gene expression. Reducing the inflammatory background does not reverse structural nerve damage, but it reduces the pain amplification that makes existing damage feel worse than the structural injury alone would produce, and it removes one of the inputs actively contributing to ongoing deterioration. The vasa nervorum, the tiny blood vessels that supply peripheral nerves with oxygen, are among the first structures damaged by chronic blood sugar toxicity. Restoring and maintaining adequate circulation to these vessels is a direct component of nerve protection, and gentle physical movement is the most accessible tool for doing so. Walking for 10 minutes after eating produces two relevant effects. It increases peripheral blood flow, improving oxygen delivery to nerve tissue. And it aids glucose uptake by skeletal muscle through a mechanism that is partly insulin independent, reducing the post-meal glucose spike that would otherwise expose nerve tissue to elevated sugar levels. Research consistently documents measurably lower post-meal blood glucose in individuals who walk after eating compared to those who remain sedentary after the same meal. Intense exercise is not the goal and can be counterproductive for individuals with advanced neuropathy, where compromised proprioception increases injury risk. The target is consistent, gentle movement that maintains circulation and moderates glucose without placing excessive stress on compromised tissue. The following changes address the primary drivers of nerve damage discussed above. They require no dramatic dietary overhaul. They require removing the inputs that are causing harm and consistently providing the conditions that nerve tissue needs to function and, where possible, to stabilize. Remove liquid sugar entirely. No juice, no sweetened drinks, no blended fruit beverages. If you want fruit, eat it whole and eat it after a meal, never on an empty stomach. The fiber in whole fruit moderates the glucose response. Liquid sugar has no such moderation. Never eat carbohydrates alone. Every meal and every snack containing carbohydrates should include a meaningful amount of protein, fat, or both. This single rule, applied consistently, reduces the frequency and magnitude of blood sugar spikes more reliably than most other dietary interventions. Reduce constant snacking. 3 meals with clear intervals between them give insulin levels time to normalize and give nerve tissue the stable biochemical conditions it needs. Walk for 10 minutes after meals when possible. It does not need to be vigorous. The benefit comes from the movement itself and its direct effects on post-meal glucose and peripheral circulation. Ask your physician to test your B12 level, particularly if you take a proton pump inhibitor, an H2 blocker, or metformin. If deficiency is found, the correction is straightforward. The cost of not finding it is continued silent nerve deterioration. Reduce the primary inflammatory dietary inputs, processed food, refined sugar, and excess alcohol, and increase the anti-inflammatory inputs, fatty fish, olive oil, vegetables, and whole fruits eaten with meals rather than alone. Anyone offering a cure for established neuropathy is overstating what the evidence supports. Nerve regeneration is slow, partial, and in advanced cases absent. That is a biological reality. But it is equally untrue that nothing can be done. The research is consistent. Stopping the inputs that cause damage stops the damage from progressing. Correcting nutrient deficiencies that compromise nerve structure stops that specific mechanism of deterioration. Reducing inflammation reduces the pain amplification that makes existing damage feel worse than the structural injury alone would produce. And stabilizing blood sugar, not achieving perfection, but removing the repeated spikes that constitute the primary toxic exposure, is the foundational intervention on which everything else depends. Less burning at night, better sleep, more stable balance, fewer falls, greater confidence walking. These outcomes are achievable in many cases without dramatic intervention. They require identifying the inputs that are causing harm and removing them consistently over time, before the damage reaches the threshold beyond which those outcomes are no longer available. The threshold exists. The window to act before reaching it is open. What happens inside that window is the only variable that still matters.